Good morning, good afternoon, good evening, wherever you are. Welcome to our webinar, Addressing Racial Inequities in Health Outcomes During COVID and Beyond. I'm Shailey Prasad, the Executive Director for the Center for Global Health and Social Responsibility at the University of Minnesota. This particular webinar is the third in a series on Envisioning the Future, Advancing Human Rights in a Time of Crisis. This webinar series is co-sponsored by our center and the University of Minnesota's Human Rights Lab. The goal of this series is to advance human rights in this challenging time by identifying the gaps in protection, opportunities for new forms of advocacy, and proposing legal and policy changes. We've had two prior webinars. The first one, Revisiting the Rights to Health, State Responsibility for the Highest Attainable Standard of Health in a Post-COVID World, was on April 28, 2020. And the second one, Balancing Rights and Responsibilities During the Pandemic and Beyond, was on May 21st, 2020. Recordings of those two webinars and today's are available at our website. Today's one will be available after a day. If you're on Twitter, please follow us, #EnvisioningFuture. It's my pleasure to introduce today's distinguished panel. We have Professor Tendayi Achiume. She's a professor of law at UCLA School of Law and the faculty director of the UCLA Law Promise Institute for Human Rights. Professor Achiume is also a research associate with the African Center for Migration and Society at the University of Witwatersrand. The current focus of her work is global governance of racism and xenophobia and the legal and ethical implications of colonialism for contemporary international migration. In November 2017, the United Nations Human Rights Council appointed Professor Achiume the UN Special Rapporteur on contemporary forms of racism, racial discrimination, xenophobia, and related intolerance, making her the first woman to serve in this role since its creation in 1993. Professor Racial Hardeman is a tenured associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. Professor Hardeman is a reproductive health equity researcher whose program of research applies the tools of population health science and health services research to elucidate a critical and a complex determinant of health inequity, racism. Professor Hartman is a McKnight Presidential Fellow at the University of Minnesota, and she recently received the Academy Health Alice S. Hirsch Emerging Leader Award for the impact her research has had on health policy. And our third panelist is Professor Sirry Alang. Professor Alang is an Associate Professor of Sociology and Health, Medicine and Society at Lehigh University, Pennsylvania. She's also a founding co-director of the Institute of Critical Race and Ethnic Studies and chair of Health Justice Collaborative at Lehigh University. Dr. Alang's research explores the role of social structures and institutions in creating inequities in health status and many health outcomes across the globe. She's particularly interested in how racism and other structures and mechanisms of exclusion shape health outcomes over the life course. I'm particularly thrilled to have these three panelists for today's session. As we all know, structural inequities between Black and white Americans have always had devastating impacts. And these disparate health outcomes have become even more apparent in the COVID-19 era. As Dr. Hardeman notes, these disparities start at birth, where Black mothers and infants are more than twice as likely as white mothers and infants to die around the time of childbirth. Similarly, we've all heard the news that Black Americans contract the coronavirus at higher rates and are more likely to die from it. And with that introduction, I'd like to bring in Professor Achiume. How does the US's record of systemic racial injustice relate to its international human rights law obligations? Many are equating police brutality against African Americans as a public health crisis. How does that approach differ from the human rights approach? And have you seen this in other countries, the racial and economic disparities similar to the US? Professor Achiume?
Thank you very much. And thank you so much to colleagues at the University of Minnesota for including me in this conversation. I am by no means a public health expert, so I'm really thrilled that my co-panelists epitomize public health expertise, but really appreciate the opportunity to connect the public health conversation to the broader conversation around systemic racism, and to also shed some light on the relationship between dynamics in this country and then international human rights obligations. So I want to start off by saying it's really important that you all at the University of Minnesota are holding this conversation, just because the murder of George Floyd in Minneapolis has really laid the ground. His murder and then the national response, the local response there, has really paved the way for what we might think of as not just a national, but a transnational uprising against systemic racism in the context of law enforcement. And so I want to name the power of the movements that have allowed for that murder to be one that forces an opportunity for systemic change, and to also highlight that the power of movements and the power of Black movements in particular in the US have been really central for the biggest contributions that the US has made to even the establishment of the international human rights obligations. So what I want to do in my time is talk a little bit about as I mentioned, the US's relationship to international human rights obligations on racial discrimination. And I want to anchor my reflections in the International Convention for the Elimination of Racial Discrimination. So this treaty, which we lawyers refer to as ICERD for short, or the Discrimination Convention, contains the most comprehensive framework for combating racism, including systemic racism at the international level. And the US, which is a complex actor on the international stage and does this a lot and has done this a lot in the context of human rights obligations, played critical roles in establishing the treaty, right? So in the negotiation of the treaty, which happens in the late 50s and the 60s, you actually see that civil rights leaders in the US who are doing important work to fight for racial justice in this country are also involved in the drafting of that treaty as well at the international level. And the work of Professor Tim Lovelace, who will be starting at Duke this year, just gives a really powerful history of the role that civil rights leaders played in even getting us those international standards that we have. That treaty ends up being adopted in 1965. But it takes the US until 1994 before it ratifies that treaty, right? So the treaty exists, but the US refuses to even become bound by the treaty until the 90s. And I think that speaks volumes to the nature of the US's commitment to combating systemic racism domestically using international human rights standard. And you see this in other areas of international human rights law, where the US wants to take a leadership role, but doesn't want the standards applied to it and to its domestic situation. And that dynamic, I think, pervades interactions between the US and the international human rights system. I want to be careful and say again, when we talk about the US, we have to be careful not to talk in too broad strokes. There is the nation of the US, which has international legal personality. But even in this moment, we might ask who or what is the US, right? We have the national administration, and then we also have people out in the streets who are articulating a critique of systemic racism that resonates very much with international human rights standards. So that tension and that bifurcation is really one that's worth keeping track of. In terms of how the US has fared since it agreed to be bound by this international human rights treaty, it has fared poorly, and it has fared poorly relative to other countries in the world, even though I don't think we should make comparative analyses. I think every country should be treated on its own terms. But given the economic and political might of this country relative to other countries in the world, it has done a really poor job of complying with international human rights obligations that apply to systemic racism in the law enforcement context and the public health context as well. And it's done so in ways that that are a combination of different things. So one thing is that in adopting the treaty, when states sign on to treaties, they sometimes make reservations. They say, we're signing on to this, but there's these things that we're not going to do. The US has a number of reservations to this treaty that are really problematic. the US hasn't taken the steps to provide the domestic legislation that would make that treaty at the international level something that people in the US could rely upon to hold the government accountable. So it's created a barrier to the capacity of people within the US to be able to use international human rights mechanisms domestically to fight racism. And so that's a problem as well. And then it's also failed to sign the declaration that would mean that citizens in the US could go to the international level and lodge formal complaints to the treaty body, the Committee for the Elimination on Racial Discrimination, that actually hears individual complaints. Other countries have done this. And so if you are from, say, X country, and your country has allowed for that declaration to be made, you can actually go to the UN and say, I'm filing a complaint against my country under this treaty. And the US has made that impossible. But I think more broadly, what's troubling is reading the reports and the human rights analysis at the international level, which across the board raises serious concerns with the US's failure to comply with international human rights law. So that's the general take-home message, is that the US, which was involved in drafting the international standards, has also been absolutely terrible in enforcing those standards. And I would say that in terms of engagement with the international system, that has been, across different kinds of political administrations. When it was ratified in the 90s, it was a democratic government, but still there's a lot of work to be done that can't just be attributed to who's in office right now. So that's the first point. And then on your second point, which had to do with police brutality as a public health crisis, I think the connections there are many, and I'm looking forward to hearing from Dr. Hardeman and Dr. Alang, who are the experts in this field. But what I will say is that from a human rights perspective, what you see both with law enforcement and police brutality in this country, and then also the public health pandemic, is that they really unveil how systemic racism is an existential threat, right? It's a thing that people are dying from on a daily basis, and they're dying from it as a result of structures of exclusion in the medical, in the public health context, right? So the mortality rate the maternal mortality rate that you mentioned at the beginning, I think speaks to that. And then they're also dying, and those structures, structures of systemic racism in the law enforcement context are killing people. And we know this from the death of George Floyd, Breonna Taylor, then there's an endless list. And that it's not just about individual bad actors, it's about entire systems that perpetuate systemic racism in ways that are not abstract and out there in the air. And so this is the point here. The point is that both of them, I think, speak to the existential nature of systemic racism. And I would say that the pandemic is forcing a conversation globally, and then the pandemic in the context of the public health, but also the pandemic in the context of law enforcement, is forcing a conversation at the international level about systemic racism that I would say is new and is different. And I think that credit for that has to go to the movements that have been doing the work all along to get these issues on the agenda. So I could keep going, but we'll pause now and hopefully in the next round add a few other thoughts. But thank you so much for including me in the conversation.
Thank you, I really appreciate that. Before we go to our next panelist, I want to remind our audience that if you have any questions, you can type it in the Q&A section, and we'll moderate the questions as they come. Our next panelist is Professor Hardeman. Professor Hardeman, how has structural racism affected overall health outcomes of Black Americans, particularly in the field that you're passionate about, reproductive health? How do these disparities affect reproductive health? What steps should we take to diminish the impact of COVID-19 on African Americans and indigenous communities?
Thanks, Dr. Prasad, for having me and including me among these esteemed panelists. And I think, this is, I think as Professor Achiume just described, we are in a unprecedented moment and unprecedented time right now to have some really important and really tough discussions about the reality for Black communities, Indigenous communities in our country. And, you know, I think a lot of what we know and what we're hearing now is not new to many of us, particularly those who come from those communities, but we are in a time where we're able to move a lot of important work forward, I think. And so I'm gonna spend a little bit of time talking about structural racism and really walking us through what that means, particularly within the context of two important crises in our country, COVID-19, and also the maternal mortality crisis, which over the past few years has gotten a lot of attention and intervention, but we still have a long ways to go in that respect as well. And then I hope to be able to really have a conversation with all of the folks who are listening in today, because I think we have a lot to say around sort of solutions and thinking about where do we go from here. So I'm going to start by just offering a definition of structural racism that I think is important just for level setting, and that's that it refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing systems like housing, education, employment, earnings, benefits, credit, policing, and criminal justice, to name a few. I think it's also important to recognize that these patterns are and practices reinforce discriminatory beliefs. They reinforce values, our value systems, the way we socialize, the way we raise our children, as well as implicit biases, implicit racial bias, and as well as the distribution of material resources. You know, the concept of race was created as a classification of human beings with the purpose of giving power to white people and legitimizing the dominance of white people over non-white folks. And that's what we call white supremacy, which is, I think, a phrase that we have to get very comfortable, or a lot more comfortable discussing as we figure out the ways to move forward and move through the current times. You know, and often in my work, the question is, how did we get here, right? It's how did we arrive at this moment where we're seeing these vast inequities, whether it's in reproductive health and maternal mortality and COVID or something in between. And, you know, one of the things that I always feel like it's important to put out there is that we can't figure out how we got here if we don't understand our history. And by that, you know, I think my colleagues and I in our recent publication talk about this and really sort of lay out the fact that we got here because we live in a country established by indigenous dispossession and genocide. We live in a country that allowed the racial ordering of humans because of slavery and capitalism. And we got here because it was profitable. And we have to understand that, and we have to grapple with that reality and that history to be able to sit with what we're currently seeing and what COVID-19 has laid bare and what the murder of George Floyd has allowed to unveil for a lot of Americans who have been able to sort of sit back and be unaware of these realities. So, you know, I think I have a couple of examples. You know, one being the fact that, you know, COVID-19 is disproportionately impacting Black Americans. We know, we've seen the data, and, you know, we've seen different counties and cities across the country where this is the reality. And we have to be thinking about what can we do on a population level to intervene and to think about how to do things better and do things differently. I think for those of us who study racial disparities and racial inequities on the day-to-day, we're not shocked by what we're seeing, but I talk to a lot of people you know, every week, really, who are surprised, who you literally use the word, I'm surprised or I'm shocked. And these are physicians. These are people who are in the hospital systems and seeing, you know, seeing what COVID is laying bare with respect to racial groups, the impact on racial groups. And so, you know, I think I hope we can have a discussion about sort of where we need to go with respect to that. And I think we also have a lot to learn, right, about from the maternal mortality crisis. So, you know, 3-4 years ago, we saw, you know, new headlines lines, particularly after Serena Williams gave birth, we began to pay attention to the fact that as a nation, as a country, the US, as an industrialized country, had this rising maternal mortality rate, the only industrialized country in the world that had a rising maternal mortality rate. And then we started to sort of peel back the layers and look at things even closer and found that Black birthing people are 3 to 4 times more likely to experience maternal death. And since then, due to, I think, excellent journalism and excellent scholarship, we have been able to identify racism at the root of that and understand how it's operating within maternal mortality. And also, there's been an incredible, I think, push at the policy level to think about the ways that we do things better and that we offer and ensure that Black birthing people have opportunities to thrive. And so I think there's a lot to learn from the maternal mortality crisis and what we're doing there. And I hope to be able to have that discussion in the Q&A as well. I think maybe I'll pause there for now, because I think we're going to jump into the solutions, and that's what I'm most excited about sort of putting out there. So thanks again for having me.
Thank you, Dr. Hardeman. Professor Alang, welcome. In what way is police brutality a social determinant of health? What are the political and societal conditions of public health crisis, responses to them, and potential violations of human rights in the course of such responses?
Thank you so much, Dr. Prasad, for having me. And I appreciate the other panelists, Dr. Hardeman and Dr. Achiume. I think my response would just follow along and fit perfectly well with Dr. Achiume's conversation about systems of oppression and Dr. Hardeman's conversation around more specifically structural racism as one of the most enduring systems of oppression that has targeted especially Black and Indigenous communities. And so police brutality, I think about it as a social determinant of health. And police brutality, first off, when we think about police brutality, it's really easy for us to focus on the excessive use of force by the police, but police brutality is broader than that. It also includes things like emotional and sexual violence. It includes psychological intimidation by the police. It includes things like verbal assault. It's a form of violence. It also includes neglect. And these are forms of brutality that affect health outcomes of marginalized communities, of racialized communities in the US and globally. And so police brutality constitutes violence that is far beyond the simple misconduct of a police officer. It really is about action that dehumanizes and that degrades a victim with or without the conscious intent of the police officer. So we see arguments of, well, the officer was afraid for their life, they didn't mean to. It really doesn't matter what the officer meant to do. As long as their action dehumanized someone, degraded someone, and fundamentally because of the color of their skin. We know, and some people may not know, the origins of the US police force really is grounded in slave patrols, both formalized and paid for to prevent enslaved Africans from escaping slavery, and also to prevent Native Americans from leaving, capturing and murdering Native Americans. And so it's sort of this foundation, how did we get to the point where police disproportionately inflict violence on Black and Indigenous communities? Like Dr. Hardeman said, we cannot separate it from the history of racial capitalism in the United States. And so it is a social determinant of health. The social determinants of health are generally the conditions and the environments in which people live, in which people age, in which people work, play, that affect their health outcomes. But that also affect or shape their life chances. So chances of them succeeding, chances of them having an education, chances of them getting a job, chances of them reaching their 27th birthday, which Breonna Taylor could not because of police brutality. And so it is a social determinant of health because it shapes the way people die, it shapes the way people live. It's a constant source of stress You know, so for communities that have been disproportionately policed, so if every video that you see that has gone viral is a video of somebody who looks like you, you don't have to personally experience police brutality for that to affect your health outcome, right? The stress from looking at that, from anticipating that, from knowing that this can happen to someone like you, it really shapes your health, both psychological and emotional health. And I've argued in some of the work that I've done, including with Dr. Hardeman, about the pathways through which police brutality affect health outcomes. And that's really grounding police brutality and making police brutality a social determinant of health that we should care about. And I think one of the reasons why we haven't talked about police brutality as a social determinant of health as much is because it doesn't affect every racial group equally. It is a stressor to particular groups of people, but it's not a stressor to other groups of people. And so it's a stressor that's in the mundane and traditional circumstances of people of color. We implicitly know that our encounters with the police may be deadly. We implicitly know that if the police shows up at your door, you know that encounter might end up with you not being alive. It might end up with you having an injury. It might end up with you being perfectly alive, but it's cost you a significant amount of stress. And so because that stress has affected people of color more significantly than it has the general population, that we haven't really paid attention to police brutality as a social determinant of health. And like Dr. Achiume said earlier, I think this is a moment where it really is an inflection point in our nation's history. And I hope that we don't go back to normal, that we really think about ways of dismantling police brutality. And I also look forward to really talking about the solutions. But one of the first ways through which it affects health, so one of the core definitions of public health, or the core functions of public health, is that it is what we do to prevent disease, and it is what we do to ensure the health of a population. Police brutality is a public health crisis because it serves the exact opposite. It is associated to disease, it's associated to injury and death. It takes away from resources that prevent access to healthcare, or it takes away from resources that matter for health in general. So the most basic way in which police brutality affects health is that it increases mortality. So a lot of people have died from police brutality, right? Tony McDade, George Floyd, we talked about, Ahmaud Arbery didn't die from police brutality, but the same sort of assumption that he's a Black man and that he was less deserving of living or being given the benefit of doubt. It's sort of the same ideas or perspectives that shape police brutality. And so it affects health directly because it kills people, it increases levels of physical injury, it increases level of mental illness. There's tons of studies that have shown the connection between police brutality and a host of emotional problems: schizophrenia, bipolar disorder, depression, number of days lost from work because of mental health conditions. But police brutality also, affects people's emotional well-being, their productivity, their ability to function, right? So think about the number of times that, we have, and I remember one time going to my class and telling students that I just wanted to take the day off today and take the day off as a Black person. And it was right after Philando Castile was murdered. And you come into work and you're expected to conduct business as usual. Somebody that looks like you was just killed for no reason. And you're stressed about that. And you come into work and you have to function and so it takes a toll on your productivity, it takes a toll on your ability to enjoy the simple things in life. Well, think about the organizing, think about the protesting, think about the sort of the secondary sources of stress, right? So Tatiana Jefferson is an example. Was playing video games with her nephew, got shot, died. And then a few months later, her father died. And then a few months later, we found out that her mother died. We still don't know, right, the connections between police brutality and the causes of death for family members of victims of police brutality. So it really does take a toll, not that it just affects the health outcomes of direct victims, but the impact that it has on communities at large. So legal bills, funeral bills, financial bills, it takes away from resources that really matter for health. And recently we've been trying to connect the police brutality and how it affects our trust in medical institutions, how it affects our relationships with our healthcare providers. And we know that police brutality shapes our relationships with the police. We know that police brutality shapes our relationships with law enforcement. But how does that, the racism that we experience in one system, how is that carried over to another system? I was talking to someone recently and I said, the racism that I might experience when I encounter a police officer, that experience, I don't leave that experience home when I go to talk to my healthcare provider. That experience shapes my encounter with my healthcare provider. That experience shapes my encounter with my colleagues. And so the impact of racism, whether it's from police brutality, whether it's because communities to which I belong are disproportionately dying from COVID-19, that affects every other aspect of my life. And I think one of the questions that you asked was about the societal and political responses to public health crisis and what the implications might be. I think it's very important to think about public health crisis of, well, police brutality, racism, the public health crisis of COVID-19, the public health crisis of maternal mortality as not existing in a vacuum. All of these crises exist because we have created a society. The society was founded in a way that our safety net systems don't work well. People aren't going to be able to just stay home from work or say that they are going to, some of the societal measures taken to prevent the spread of COVID-19 or to limit the impact of COVID-19, right? Social distancing, for example, working from home, for example. Our society is not set up to ensure that, or to make sure that everybody has equal ability to be able to do that. And so because our society is unequal to begin with, and because some people are able to stay at home at the expense of others who are not able to stay at home, and that again is really classified by race and skin color in the US. I think it's really important to highlight that our response to police brutality and our response to COVID-19 and our response to maternal mortality and our responses to all of this public health crisis should really be connected. We can't separate or isolate and address police brutality without thinking about maternal mortality, without thinking about COVID-19. It is the same white supremacy. It is the same structural racism that manifests in all these systems. And that's really the idea of structural racism, that it's not just within one structure that you experience health outcome. It is across different structures. It is across different systems. And so I think it's really important for us to highlight that. The last thing I want to talk about, sort of our political response, is how we enforce public health measures, right? So I think most of us are familiar, but some people might not be familiar, that the majority of people who were arrested for not keeping or for not following social distancing guidelines were Black and Indigenous people and Latinx communities, right? And that is because we cannot, our system is fundamentally flawed in that in the middle of a public health response that we expect law enforcement to enforce public health measures, to continue to foster the distrust between communities that are disproportionately policed and communities that are disproportionately impacted by this public health crisis. So I think thinking about going back to how we got here to begin with is really important for thinking about how we respond in moments of crisis. But I also think it's important to think about how we build a society that the probability of you dying from COVID-19, from you contracting COVID-19, doesn't depend on the color of your skin. I think we have to think about creating a society where the probability of you being killed by the police or being affected by police brutality doesn't depend on the color of your skin. That way, I think being proactive and creating a more equitable society would come a long way, that our reactivity when crisis happens would be met with less inequities in terms of the responses. I'll pause here for now, and I really look forward to the conversations and questions.
Thank you, Dr. Alang. Just a quick announcement. We just got to know that we've had 500 participants. That's the capacity of our Zoom. And if you have friends who've been trying to sign in, can you please let them know that this is being taped and it'll be available at our website 24 hours from now. Moving on to next set of questions, and this is to set the stage for the future. And this is for the entire panel. What are the best strategies for addressing these disparities moving forward? And what gaps do we need to address on a national or international level to guarantee the right to health for all in a post-COVID world?
Go ahead, Dr. Achiume.
All right, I'll go ahead. So, I think that this is a question that can be answered at multiple levels. And I think the level at which I will answer it is thinking about individuals, and then also thinking about the human rights community. I think the reflections for individuals will likely apply to people in the public health space. So I think one of the biggest challenges to fighting racism and fighting systemic racism is just denialism about the nature and the existence of the problem, right? And in my work as special rapporteur, it's an interesting thing that happens. People who experience racial discrimination have of course, experiential understanding of the nature of the problem, and you don't really need to convince them, or they're unsurprised about claims that there is racism in a particular context. But I can't tell you how many people I encounter who understand themselves to be good faith, liberal individuals committed to human rights and even committed to fighting racism, who will nonetheless then follow that up with saying, but I don't see the problem of racism here, right? So just at an individual level and even at a structural level, I think what this moment is pushing for is for every person, no matter where you are watching this Zoom from and no matter what your positionality is, to really pause and take seriously that, because you have not experienced something and because your position in life makes a particular experience difficult to even conceive of, that cannot be the basis for whether you decide that something exists or not, and those kinds of blind spots that are born of privilege exist everywhere, not just in the context of racial discrimination, gender discrimination, sexual orientation discrimination, class discrimination. And so this is just saying, thinking intersectionally and really internalizing that what this moment is showing us is that systemic racism isn't an imaginary or even understated problem. It is an urgent, and as I mentioned, existential one, and really thinking about how as individuals we think and approach these problems, I think is one of the most urgent things that has to come out of this moment. And then just pivoting a little bit to the human rights universe. And I think this is relevant even for people who don't understand themselves as human rights advocates, but who are interested in the relationship between law and policy and equality and equity on the ground, which is that there's actually a big gap between the domestic standards in this country and the international standards around equality and non-discrimination. And the international standards are not perfect, but they in many areas are better. And so here, the push is to say that human rights advocates, and then even people who don't use that frame, take seriously what the international human rights framework has to offer in this context. And I'll give you a concrete example that actually also ties in one of the questions that came through from the Q&A. So in terms of how you define racial discrimination, what is prohibited racial discrimination? One of the criticisms that have come from the international level about the US's approach is that even the way that it defines prohibited racial discrimination in much of the federal legislation pulls apart from the international standard. So at the international level, prohibited racial discrimination isn't just about intent, right? So in the domestic regime, there can be an emphasis on looking for a bad actor, somebody who was a racist in a moment and resulted in somebody being treated differently. And at the international level, there's indirect discrimination. It's not just about bad actors who are explicitly motivated by prejudice. It's about outcomes. It's about differential outcomes. It's about disparate impact. And in the US, there are some corners of law that still permit of disparate impact being insufficient to prove prohibited racial discrimination. But there are many areas of law where that's not the case. And unless you can produce a racist, intention somewhere, then you're out of luck. And so much of what we're talking about on this call is showing how you can have really brutal structures of racialized exclusion, even without even being able to line up the individuals who are holding the intention to oversee it, even though some of those people are also in the system, right? So just even in terms of how we define prohibited racial discrimination, there is benefit to going outside of the domestic system. And I've said this in other contexts, the human rights movement itself has marginalized racial discrimination and racial equality. So human rights organizations like Human Rights Watch, other big ones that operate in the US, because of the same dynamics that, we're talking about. Structural racism is not, the human rights system is not, shielded from it, and human rights actors are not shielded from it. So this is a moment for deep reflection, including within the human rights community, about where we place racial discrimination and racial inequality in the hierarchy and how we approach it. And one final thing I'll say on this, and again, this ties to something that was raised in the Q&A, and it's a good question to ask, right? So one of the main challenges to using international human rights standards and to deploying them and to having domestic regimes really be connected to the international system is this concern for nation state sovereignty, right? So this idea that the sovereignty of the country is going to be undermined if we allow international standards to tell us what we should do in whatever domestic context. And there's two things that it's important to note here. One is that the way that the international human rights standards are articulated is that it's failures of nation state sovereignty that result in human rights inquiry, right? It's when a country behaves in a way towards its citizen, in a way that fundamentally undercuts the rights of that system. So to say that this is an infringement of nation state sovereignty is I think, to characterize what international human rights law is supposed to be doing. It's supposed to be ensuring that nation state sovereignty is used in ways that protect individuals, especially minority groups who in the country have no means of expressing or participating in that sovereignty, which is the situation in the United States, right? So if you are a Black person or a person of color, an indigenous person within the US, nation state sovereignty is at the center of your subordination, right? And if you cut off the international system, essentially what you're saying is you can't get domestic relief, but you also can't get international relief if you are experiencing racial discrimination, racial inequality. And oftentimes structural racism is about also political hierarchies. There are people with political power, people without political power, and that's a racialized hierarchy. So when you try and insulate the nation state sovereignty of a country that has those racialized structures of inequality, basically what you're saying is no human rights for people of color in the US. So I think it's worth it to really interrogate sovereignty-based resistance to the international system, because it is most dangerous when imperial nations, and I'm thinking of the US as an imperial nation, or a kind of, imperial nations that have an animal farm approach to sovereignty, where it's like, we're all equal, but some are more equal than others. We really have to be suspicious of that and reject that. And so I'll leave it there for now.
Thank you. Dr. Hardeman?
Sure. So I think, Dr. Achiume, you said something really important at the beginning that I think is really relevant to the public health lens for this. And that's what you said around sort of the blind spots born of privilege, right? And the fact that, we have, this sort of overwhelming desire. I think in public health, we go into public health to do good and to do the right things, but there's these blinders and these blind spots that end up doing more harm. And, one of the things I think we have to be doing and thinking about very clearly and very carefully right now is how we center at the margins and how we make sure that we're shifting what we consider to be normal, what we consider to be the standard, or, even in research, what we consider to be the questions that we're asking, or the comparison group we're comparing these, these inequities to. And I think that also requires us to think about and rethink who our leaders are, who's willing to give up power, who's willing to step aside and say, for the greater good, I'm not the right person to be leading. And that's okay, and we can figure out ways to move forward in that space. And that, you know, I think that has to be happening along with you know, efforts around. So there's a lot of, you know, I think there's a lot of work being done in the training space of, you know, we're going to train our way out of this racism problem. And while that can be a starting point, and understanding, you know, particularly for those, you know, as you know, we just heard that there's, for those who this isn't their lived experience, yes, you know, learning that and understanding what that reality is incredibly important, but it can't be where we stop. And then the third piece is, you know, what are the policy levers that we need to be thinking about, both with respect to the current crisis around policing and COVID, and but also with respect to maternal mortality and all the other ways that we're seeing these inequities play out in our society, and you know, and working sort of simultaneously at all different levels to do that work. And you know, I think one of the concerns, or one of the things we haven't done, and I think we have an opportunity to do right now, is to lead with equity. So we are often thinking about equity as an afterthought, and thinking about anti-racism as an afterthought, because someone, you know, usually the person of color in the room is bringing up that, you know, that concern or that issue. And, you know, we've seen over the past 3 months how our healthcare systems can innovate and can think differently, and can, you know, turn on a dime to offer different, you know, telehealth or whatever it may be in the face of this crisis, this global, you know, pandemic. And so I think we do, you know, that to me, that suggests we have this ability to be innovative in other ways as well. And we have to decide that we value that, and that we are going to take that on in the way that we've taken on addressing the global crisis of COVID-19.
Dr. Alang, if we can bring you in.
Yes. So a couple of things that I want to add. Well, I want to emphasize one thing and then add another thing. I think the important thing that I really want to emphasize is that this is the time for us to really evaluate critically how knowledge around understanding human rights, understanding structural racism, understanding health inequities, how that knowledge is produced. This is the time for us to think about the epistemologies that shape our understanding of racism and of public health. One of the most basic things, I think Dr. Hardeman's research has looked at that. How do we even talk about racism? How do we talk about white supremacy? And the fact that we don't talk about these things and engage with them doesn't make them go away. They don't just go away because we don't engage with them. I think we have to rethink the way that we've created knowledge. We have to think about knowledge production. We have to think about the voices that we have essentially, you know, privileged in the creation of knowledge. We have to think about the voices that are at the forefront of policy making, especially when it comes to literally every policy affects health. So not just in terms of health policy, but in education, in our criminal justice system, in transportation, in housing. Every single policy creates inequities in health outcomes because they are connected to health. And when we talk about the social determinants of health, we talk about collecting data that matters for health. But how much have we valued or invested in collecting data that really gets us to understand structural racism, that really gets us to understand white supremacy? And we can't do policy without the data. And if the policy, for the most part, is influenced by, policies tend to reflect the perspectives and decisions of the people who make the policies, not the people who are impacted. And so if the centering at the margins piece is really important, that whose voices not just inform the production of knowledge, but which voices inform the legislation of policy, and how are the perspectives of people reflected in that, who's at the forefront of that. And this is not something that you can only do if you're a policymaker or if you're a chair of a department, or this is something that every single one of us can do. And sometimes it's, you know, I find it really surprising, our outrage against police brutality. It is the exact same racism in police brutality that operates in our day-to-day spaces. I think the issue is that nobody has produced a viral video of what goes on in our admissions committees. Nobody has produced a viral video of what goes on in our nursing home facilities, how they treat people of color. Nobody has produced a viral video of how, you know, the racism that occurs in our housing institutions, impact and murder people of color. And so I think that it's important for us to join the chorus of saying the police has to change, of defunding the police. It's important that we do that, but I think it's also more important for us to think about our little corners of the world and to think about how we sustain racism and white supremacy. I think it's often easy for us, and I do that too. I think it's easy for us, and I even said it here, to say it's a big institutional problem. In some ways, it's like you're removed from that institution, but look around you, we are the institution. And we have to be able to hold our institutions accountable. We have to be able to develop systems that are accountable to people whose health we influence, that are accountable to people who are dying from COVID-19 and from police brutality. So I think that thinking about a solution first requires us to reflect on what we do and be brave about it. There's no perfect or convenient time, to address racism, or there's never a best moment. Every time is the best time to talk about racism. And I think one of the things that has sustained racism and that has sustained white supremacy is just the simple denial of it. I think we have to get past the point of making justifications and really confronting head on our own failures and our own role in continuing the system that has, oppressed people for centuries.
Thank you, Dr. Alang. We've had a bunch of really excellent questions. I'd like to get Dr. Achiume's opinion on this. Have you seen examples from around the world where there's been an active dismantling of structural racism and a way to move forward in any aspects of racism?
So this is a really hard question, and I think there are better and worse cases and all over the world. So the way I understand the most pervasive structures of racism is that they're related to historical imperial projects, right? Colonialism, slavery, and then others that we don't talk about as much, but that similarly have that dynamic. And I think they have been great successes in some ways. Formal decolonization for many countries, to me, speaks to some success in undoing structures of racism, because what was formal colonialism if not a transnational structure of systemic racism? That said, decolonization didn't solve all of the problems, right? There is still structural racism on a global level, and even in countries like the US, for example, that have implemented all kinds of formal measures of trying to integrate people of color into the political community. The reason why we're still having this conversation is because those have failed, or they haven't been sufficient. So, in terms of a general statement, I think it's hard to say this country has absolutely succeeded and this one has failed, but there's definitely areas where you can make comparisons. And I think the context of policing is one where you can definitely make comparisons between what happens in the United States and what happens in other countries. And even just as simple as the use of guns and how normalized it is to have fatal shootings in the US. I would say that's something that other countries, including countries that the US considers its peers, it's an outlier in that sense. And there was actually a report that, human rights report that came out from the University of Chicago's International Human Rights Clinic that actually looks at use of force within police departments and finds that in the biggest ones in this country, they're just all out of step with international human rights standards, and there are countries that are in step. So in the context of policing, in the context of criminal justice, any of you who've been to a prison in, say, Western Europe, again, I'm mentioning that because I think the US likes to think of Western Europe as its, that's the peer group. Prisons in that part of the world and prisons in this country, it's not even comparable. The institutions are just different. And it's, I have been to the Los Angeles County Jail, and I've been to a maximum security prison in the Netherlands, and it's worlds apart. You can't even begin to compare them, because the maximum security facility there, is worse. Sorry, that's my alarm. This is very bad form on a webinar. But so, I think there are areas where you can make comparisons and say the US is faring worse off. I think we have a global problem here that requires fixing, so no country should be off of the hook. And then the final thing, I will say on this, which is gone because my alarm went off. If it comes back to me, I'll just jump in, but otherwise I'll stop there.
Thank you. Dr. Hardeman, a set of questions was about racism and reproductive outcomes. So there's a whole lot of questions as to what are the roots around it and why is there still so much of racism? Is it a structural thing from healthcare systems, or is that beyond that?
Sorry, I was muted. Sure. So what we know with respect to maternal mortality is that racism is playing out in a variety of different ways to impact those and influence those outcomes. So, you know, on the structural level, you know, I often use the example of housing and residential segregation and help folks to understand the ways that structural racism is playing out and that outcome are in birth outcomes and maternal outcomes through redlining. You know, so a racist policy historically that dictated where Black people and Black families were able to live, if they were able to get, you know, mortgages and buy homes in certain communities. And literally, you know, you could draw red lines dictating which communities those were. And then what we see is that the communities where Black families were forced to live were communities, and are communities that are, you know, disinvested in. There's fewer access to material resources, fewer opportunities for education, and all of these other social determinants, right, that we've heard a lot about from Dr. Alang. And so we know that you know, through the weathering hypothesis, and that chronic cumulative disadvantage over the life course often brings Black birthing people, regardless of their socioeconomic standing, regardless of their education levels, into pregnancy and childbirth worse off than their white peers. And so we have these sort of structural inequities that are playing out on that level. And then the other part that we, you know, have learned, you know, both within the maternal health space, but also in other contexts, is that there's racism playing out within the healthcare and the clinical encounter. And, you know, that can't be separated, in my opinion, from the structural factors, because it's all sort of perpetuates itself in a lot of ways that we don't have time to discuss today. But, you know, we see implicit bias and things playing out in the clinical encounters that are also then dictating how care is received, the quality of care, the clinical decision-making process. And so, you know, we have to be working at things from sort of both ends of the spectrum, both within the clinical space and, you know, thinking about what we would call little p policy and sort of organizational changes that have to happen, as well as thinking about sort of the larger, you know, more structural inequities and how we intervene there to ensure that folks have the opportunity to thrive.
Dr. Achiume, you had something to add?
Yes, so sorry, it came to me, and it has to do with this comparative analysis between the US and abroad. And Dr. Hardeman, fully agree with everything you said. Sorry to kind of interject at this point, but it's wanting to point out where the US is better than the group that it likes to compare itself to, which is Western Europe. And it's better on two fronts. One, you can actually collect data in this country, disaggregated data on ethnic and racial disparities, and there are places in Western Europe where it's forbidden to actually collect disaggregated data because it's considered racist and racially discriminatory to even collect the data. So on that front, the US is a lot better than parts of Europe. And so that's important to mark. And then the other thing also is, I think we have a conversation and a discourse around racism in this country that, again, is more sophisticated than in many parts of Europe, where you have countries like France removing references to race in its constitution and substituting them with sex, again, because even just talking about race is considered to be racially discriminatory. And I think it's because you've had movements in this country that have made it difficult to get away with not talking about race. So those are two ways in which the US is better than other parts of the world.
Thank you. Dr. Alang, what do you want to see in the future in our healthcare system?
A lot. But I think for me, the first thing is that when it comes to, and somebody had talked about a magic policy, there's no magic policy. But I think that for every policy, that as much as we talk about sort of the cost effectiveness of that policy, that there should be something about how it fosters equity and justice. I just think it's completely wrong for us to pass policies that have no reference to who's disproportionately impacted, who benefits, disproportionately from those policies. I think sort of a justice analysis of a policy, racial justice specifically, is really important. It doesn't matter what policy. And then the second thing for me that I think it's really important, back to our knowledge production and other epistemologies to address inequities, I think that there are two things. I think that number one, we have to focus on the context experts. A lot of people are the context experts. They learn about this in school, they know it. They get the content, but I think we have to focus on the context. People who live this on a day-to-day basis, I think that their experiential knowledge and their experiences of inequities shape knowledge and shape policy as much, if not better, than what the rest of us study and are content experts. So I think that we want to highlight both context and context expertise when it comes to the production of knowledge.
Thank you. Unfortunately, we are out of time. I really appreciate all panelists. Appreciate you all participating and the wonderful questions that came our way. Like I mentioned, this recording will be available after 24 hours at our website. Thank you again, Dr. Hardeman, Dr. Alang. I know Dr. Achiume had to go for another webinar. Bye.